let me begin. Feel free to use the chat. Do you know who this is? If you don't know who, it's not me, by the way. If you don't know who this is, perhaps you recognize the name. If you don't know the name, maybe it would help if I showed you what he invented. If you're not sure what that is, it's actually the first machine there was for slicing bread. There is a saying in Britain that that any new invention or device or medical treatment is the best thing since sliced bread. I know that you don't approve of sliced bread in Italy, by the way. The question for you is, how long did it take for sliced bread to become more popular? Was it 1 year, 5 years, 15 years, or 50 years? Okay, so the answer is 15 years. Those of you who chose something in the middle were correct. So 15 years, and 15 years is not only how long it took for sliced bread to take off, but it's also around the average duration it takes for research to move into practice. And that is the main focus of our work. So thank you so much from Sarah and I for this opportunity to share our work. We're going to talk first of all about how we took some work in one region of the United Kingdom. This is Yorkshire, or part of Yorkshire, which actually is a relatively socially deprived and ethnically diverse population in the north of England. So it's a bit opposite to the north-south divide in Italy, perhaps. And I'm going to talk about some work we did, some research we did within the region, which was then scaled up into audit and feedback in practice across a wider region. And this work concerns work that took place in general practice or family medicine. And then we're also going to talk about how we embedded research within a national clinical audit programme in the United Kingdom. And that was within hospitals. I need to briefly thank the people who funded most of this work, which was the National Institute for Health Research. So, starting off at the regional level, this is West Yorkshire. There are 316 general or family practices organised currently within 10 groups, and the population size is just over 2 million people. And this first project was called Aspire, or Action to Support Practices Implementing Research Evidence. And what we did was we identified what we called high impact recommendations. So these are recommendations taken from clinical guidelines where there's good evidence that performing them improves patient outcomes, and where we could find where we could use routinely collected data to assess outcomes. And we also identified where there might be scope for improvement. So the first one concerned diabetes control. So blood lipid and blood pressure and glycemic blood sugar management, and how well that was done. The second one concerned blood pressure control, mainly in people with hypertension. The third one concerned anticoagulation for atrial fibrillation to prevent strokes. And at that time, most of the preventative treatment was warfarin. And the fourth one concerned what we called risky prescribing, which was mainly prescribing of non-steroidal anti-inflammatory drugs in high-risk groups or in high-risk combinations. So using routine data, we, in a sample of 89 randomly selected practices, we first of all identified variations which were incompletely explained by demographics and other factors. So whenever we look at variations, a lot of the variations are because of variations between individual physicians, which we didn't measure here, or individual practices. So then we developed what we called an adaptable implementation package, where we initially interviewed people from general practice. We conducted about 60 interviews with doctors, nurses, and managers. We used a consensus process involving similar people to develop interventions. And we were also informed by evidence on what works, as well as behavioral theory. And so that our intervention package mainly comprised audit and feedback, outreach educational meetings, computerized prompts, and also as part of the audit and feedback, practices could see which patients were not receiving optimal treatment. And within that package, we made sure that we embedded a number of behavior change techniques. And this was basically the same package, but tailored to each of the 4 different clinical problems. So then we did a trial. And when we say a real world trial, what we mean is that we did not choose special general practices to take part in this, but we included general practices unless they opted out, because we wanted to make sure that we included typical practices and not those who were more interested in research. And then we did 2 trials. In the first trial, we randomly allocated 40 practices to the diabetes control intervention and another 40 practices to the risky prescribing intervention. In the second trial, we randomly allocated 32 practices to the blood pressure control intervention and 32 practices to the anticoagulation intervention. In this way, we balance Hawthorne effects. So in other words, we can be sure that any differences between the trial arms are because of the intervention and not just because the practices were taking part and knew they were being observed in an experiment. So the question is, did this work for all 4 of the targeted problems? So did it work for diabetes control? Sadly not. Did it work for blood pressure control? Sadly not.
No.
But did it work for anticoagulation? Sadly not. But it did work in reducing risky prescribing. So that in control groups, risky prescribing was 6% versus 4.9% in intervention groups. And the intervention was broadly cost effective. Now, one important thing is that the absolute intervention size here is quite small. The effect is just about 1%, but across a large population, that starts to make a difference. So this was something which could be scaled up across a population of over 2 million people. We also think that there were reasons why risky prescribing worked better than the other 3 parts, the other 3 targets, and it's probably because prescribing was within the control, or more within the control of the prescribers. In other words, the people being targeted by the feedback. So I'm going to hand over to Sarah. Thank you.
Thank you very much, Robbie, and thank you for having us here. So we are following this. We were doing some other work locally that looked at prescribing of opioid medications, so painkillers such as morphine and codeine. And what we showed is that the prescribing of these medications in primary care had doubled in the 5 years, so that the number of patients taking these medications for long-term chronic pain had increased, but particularly the prescribing of strong painkillers. And there was quite a considerable variation between practices, which was not completely explained by either the practice demographics or the patient demographics. At the same time, there was increasing evidence that there was an opioid epidemic, as it's called, or crisis in the United States. And there was more and more evidence that people taking these medications were suffering harm. There was risks of addiction, overdose, fractures, and ultimately increased mortality in patients taking these medications. So following on from the Aspire work, we suggested to the 10 clinical commissioning groups, who are the groups of practices, that they might want to think about an audit and feedback project where we deliver the feedback to all practices as a quality improvement initiative and see if we can change their prescribing. So this is the feedback that we delivered, or part of the feedback. So it contained all the evidence-based or current evidence-based in audit and feedback. That's Jamie Brehout has probably talked to you about already. So there was both a visual message and a sort of summary message. It was provided 6 times over the course of the year, so every 2 months. We compared practices to other practices in their local commissioning group, which is their local area, as well as within the wider West Yorkshire population. We tried to make it quite easily interpretable as to what they were trying to achieve, and it was very practice specific. So this was delivered over the course of the year. And following this, we then compared the prescribing of the opioid painkillers with the prescribing in other areas of the Yorkshire. So the straight lines here, the solid lines, are what happened to prescribing in West Yorkshire. So prescribing was going back up in both the intervention area and in the control area. But when it came to the intervention, we managed to reduce prescribing, whereas the control areas continue to increase, and they continue to increase post-intervention, whereas we managed to sustain an effect, although not quite as good, even after feedback delivery had stopped. Overall, the population effect, we estimate about 15,000 fewer patients were not given opioid medication for chronic pain across the population of West Yorkshire. We particularly did well in elderly patients, so over 75s, who are at higher risk of adverse effects from opioid prescriptions. And the cost effectiveness of the intervention taken into the cost of delivery meant that the commissioning groups as a whole saved nearly £1 million in prescribing costs. Importantly, what we also found, though, was that we hadn't increased referrals to places like musculoskeletal clinics, which might end up causing problems further down the sort of patient pathway if we suddenly create a load of referrals that need to be seen. We also did not increase prescribing of other analgesics, such as non-steroidal anti-inflammatories or gabapentinoids. And on the whole, GPs found that the feedback was acceptable and they liked it, and they used it within their practices to do some quality improvement work to try and adjust prescribing. Following this, because this was seen to be very successful, the commissioning groups and the medicines leads within those were quite keen to then repeat this. So this is part of how we developed a sustainable project, was the acceptability and the effects of the original opioid prescribing. And we have since delivered a similar campaign to look at gabapentinoid painkiller prescribing, which is increasing a problem in the UK, although I think less so elsewhere, but that was rising by about 14% a year. And whilst it wasn't quite as successful, whereas nationally prescribing did continue going up about 14% a year, in West Yorkshire it stabilised, which was still seen as a success. And now we're currently delivering a 5-year programme to the same groups of practices on their antimicrobial prescribing to try and tackle antimicrobial resistance. And we've also now managed to successfully deliver the same intervention on opioid prescribing across the rest of the Yorkshire and Humber region. So it's not just now West Yorkshire, it's now been delivered across a population of over 5 million people. What we would like to do next, though, is rather than just deliver feedback, but to try and work out whether or not we can make feedback even more effective, to see if we can make some cumulative gains on the effectiveness of feedback. And so we are planning a trial where she's going to involve all the practices we've delivered feedback to already. And that's going to test different versions of the feedback and see if we can make that more effective and work out what works best and where. And so I'm going to hand back over to Robbie for the next part. Robbie, you're on mute.
Okay, sorry. I did a terrible job there of going through Sarah's slides in slightly haphazard order. I relaxed too quickly after I'd stopped speaking, and then if I remembered I had to move her slides. Anyway, so let's move on to the national example, which involved secondary care. And this is an example of how we managed to embed research within a national clinical audit programme. So this particular programme of research focused on the national clinical audit of blood transfusions. Blood transfusions, if you really need them in an emergency, as many of you know, are very good. But of course, like all medical interventions, they have side effects or adverse effects. And also, if you use too many blood transfusions, it's not an efficient use of resources. So another quiz. What proportion of blood transfusions are probably unnecessary in the UK? So you would be right if you chose the middle figure again, of around 20% or 1 in 5. So we started working with in a collaboration that involved the National Clinical Audit of Blood Transfusions and other collaborators. And we started off by examining current feedback practice in the National Clinical Audit of Blood Transfusions. So for this, every year, an audit group agrees new standards, and then the hospitals audit, and this is across England and the rest of the United Kingdom, the hospitals audit consecutive cases over 2 to 3 months. And then the feedback reports are delivered about a year later after the data are collected. And the feedback reports are delivered, but when we examined them, we found that it wasn't always easy to find out what the recommendations were or what had to be prioritized. It wasn't clear what action had to be taken after receipt of the feedback reports, and it wasn't clear who was going to do what after the feedback reports. So again, in collaboration with our behavioural scientist colleagues, we looked at 2 ways of enhancing feedback. The first way focused on content. So the other problem with the National Audit Report is that they were big, long reports of over 100 pages. So you had to be very enthusiastic to read them all. So we designed a feedback report which was much briefer and highlighted key findings against comparisons, again, using some of those same behaviour change techniques we've talked about before. We also provided a medium-sized report for people who wanted to know a bit more and verify the data. And then for people who were very interested, we provided the full report as well. So that was the enhanced content. And then the enhanced support intervention involved a web toolkit to help people work through what action they had to take locally, and telephone support for people receiving the hospitals receiving the feedback. We then did actually 2 randomized trials. So all UK hospitals, they got their baseline audit data, which examined the appropriateness of transfusions. They were randomized, and they were randomized. This we used a factorial design so that hospitals were randomized effectively twice into a total of 4 groups. So the 4 groups received standard content and feedback content and support, enhanced content and standard support, and so forth. So 4 different combinations. And then we used the audit data at follow-up to see if the interventions had any effect on transfusion practice. And as I said, we did 2 trials. The first trial concerned transfusions for major surgery. And the second trial concerned hematology, mainly hematology cancer patients. And both trials ran over 2015 and 16. So there you go. What do you think happened? Do you think we had a very successful intervention? So I'm not sure if you know who this is. I don't think I would recognize it without being reminded. So he was a famous field marshal, and he coined the phrase that no battle plan ever survives contact with the enemy. And it's probably fair to say that our well-designed interventions in the blood transfusion experiment actually had no effect on practice in both trials, and we found no individual effect of either of the interventions. That's what happens when you do trials, by the way. If you basically, if you ever want to show that something works, it's always best to use a weak study design, whereby if you want to get a really true picture of whether or not something works, use a clinical trial. But I know I don't need to tell you that. So how can we explain what happened here? Well, we also did a process evaluation, and that showed that the hospitals did not or could not engage very well with the interventions, but also there were issues to do with the audit itself. So, for example, we found that I think 1 in 10 of the hospitals that collected the baseline data didn't collect follow-up data. And about 1 in 5 hospitals that received the feedback reports did not actually download and look at them. And that raises a number of questions about how the audit itself was conducted. Although we're very grateful to the people in the audit who took part willingly and encouraged us to go to do this experiment. And we also discovered some issues with the credibility of the audit standards. Now, there were things that we think we did well. We delivered 2 major complex trials within a national clinical audit program. And in the course of that, we learned a number of lessons about aligning trial and audit processes. And it's also formed the basis of an ongoing collaborative relationship. But we began to reflect about some of the lessons that we'd learned in embedding research into a major audit program. And that took us on to another program of work. And Sarah's going to talk about a study from it now.
Thank you, Robbie. So this is ENACT, or Embedded Trials Within National Clinical Audit Programs. And as part of this work, I led a team in interviewing both the audit and feedback researchers, the national clinical audit or large regional audit staff, and recipients of clinical audits, so the healthcare professionals who receive this and are meant to act on results. And what we did was we explored what helps them and what stops them from embedding research into audit and feedback within the clinical audit program. So what stopped them actually conducting trials or other types of evaluations into deciding whether or not changes to feedback is more effective and increases a greater response in improvement in healthcare. So we interviewed 31 different people, and the interview guide was put together from behavioural change theory, and then we sort of collated the results, and from these results we came up with 10 top tips for successful collaborations between national or large regional audit programs and audit and feedback researchers such as the A&F MetaLab people, as to how we can increase experimentation within the sort of existing audits. So top tip number 1, thanks Robbie, is to firstly consider what extra resources the national or regional audit programs would need. We found that many of the audits we talked to described that they were running on a shoestring, so on a very small budget, and had very limited capacity to take on anything new. So quite often the research could be useful to actually get extra capacity into the National Clinical Audit Programme, which then made them more sustainable. The second one was to agree timelines between both the research and audit teams. So quite often the audit team have very specific timelines on when to deliver the feedback, and problem was the research also had timelines in terms of applying for grants and receiving funding for this, and quite often those did not overlap. And so being aware of timelines for both teams was really essential to be able to do any evaluation. Next one, please, Robbie. So, and the third one came about of logistics. And so quite often sort of processes for the data extraction, the sharing of the data, having data sharing agreements, checking and cleaning often fell down within the study, so it had taken place. And one of the lessons learned from quite a lot of the work we've done so far was to actually have a look at the data and agree on the processes of how it's going to be managed before you start doing any planning of evaluations, to know what you can get and how you're going to get hold of it, and particularly sort of the problems with routine data recording. The fourth tip, whilst it seems really obvious, but actually having a really enthusiastic leader who wants to know how to create improvements in their feedback is really helpful to drag this forward, because it often requires extra work on behalf of the audit, and it's often, and therefore having someone who's willing to sort of do that is really important. But also that leader needs to know that whilst the randomized trials like Affinity that Robbie's just spoken about don't always show an improvement in effectiveness, that doesn't necessarily mean that the audit is failing or that the audit doesn't have any impact overall. That's just part of the equipoise, that we don't know what works best at the moment for audit and feedback to create change. The next one was the sort of collaborations between the researchers and the national audit teams, and really important to agree what the priorities are for both the research and the clinical audit programme up front before embarking on any research or changes, and ensure that these are sort of aligned from both teams. But within that, it's often wise to start with small changes to the feedback and audit, rather to avoid alienating your end users. So quite a lot of the national audit teams had presented data in the same way for so long that they were worried about making big changes and actually alienating the people who look at it at the other end, with them not understanding it or not using it at all as a worst case. So we decided that small changes and building up to bigger ones was probably the way to go. Another lesson was choosing audit standards that are underpinned by strong evidence base. There are quite a lot of clinical audits, particularly in the UK, that don't have great evidence for their standard. And that creates a problem when you're trying to create change or trying to create improvement, because it's very much harder to prove that something is actually beneficial at patient level if you don't have a great evidence base for that standard underlying it. And then also to balance the research ambitions. I think as researchers, we often have great ambitions of what we'd like to do and how we'd like to change things. But again, it's similar to the previous one, us making small changes. Things have to be quite pragmatic and work within the national clinical audit that you're working with, particularly within their own capacity. And then finally, to recognise that even small improvements in audit effectiveness and feedback effectiveness may have significant population health benefits. So even a small reduction in the number of people taking opioid painkillers, I think it worked out as less than one person, 0.65 people per month per 1,000 patients, actually across a year, and a larger population works out as 15,000 patients fewer. So even small improvements have big population effects, and we need to shout this to funders, commissioners and healthcare systems who often don't see that small, who only see the small number and don't realise the larger population effects that this can create. So finally, thank you for listening to our talk. Audit and feedback, possibly not the best thing since sliced bread, but it certainly is quite exciting to do some work on trying to create effectiveness and improve population healthcare. And really, the important things we'd like you to take away are that continuous small improvements can translate into large population effects. Therefore, it's worthwhile trying to evaluate whether or not we can improve audit and feedback. Using routinely collected data allows for sustainability. All of our projects have used routine data, and that's allowed us to sort of go on and collect and continue this for different indications. But also aligning surface and research needs within long-standing partnerships is really needed, and it takes time to build up these partnerships to be able to deliver some of the research, but it's worthwhile doing when you can. Thank you.
Thank you. Thank you, Robbie and Sarah. Hi, thank you. I am Nera Gabiti from Rome, Department of Epidemiology. And on behalf of the EasyNet research team, who are now present today, I'd like to thank you very much for accepting our invitation and spend time with us, first of all. And second, I would like to thank you for your very, very interesting presentation. We thank you because you present your experience, both in different fields, in primary care, hospital, and also very interesting, your results from a qualitative interview. As Marina said before, our project is very complex, and we are now in the middle of our work. The project will end in the middle of 2023, and the 7 regions, the 7 institutions participating are now going on with the implementation of audit feedback strategies in different contexts. And we are now experiencing difficulties like you present, and the difficulty of reaching results, expected results. And so we thank you for your overview, because your presentation, your results will help us to go in a more optimistic way, I suppose, in going on. I understand your efforts, and for example, we, in our project, the original project planned to perform randomized trial, Sarah and Robbie. Because of extraordinary period of COVID and other problems, we had to change to simplify our methodology. And now we, in different situations, we change the study design, simplifying it in, for example, pre-post controlled study.